You're mute, Dr. Savant. Dr. Savant, you're mute.
Yes. Am I audible now?
Yes.
Yeah.
Yes.
I'm sorry about that. Let's begin. Good afternoon, one and all. I am Dr. 𝐂𝐎𝐍𝐍, and it's a privilege to welcome you all to the live panel discussion on episode 1 of Early Signs and Symptoms and Screening Guidelines of Colon Cancer in Indian Perspective. On behalf of Voice of Healthcare, powered by Zydus. Did you know that colon cancer stands to be the third most common cancer among men worldwide in India? Colorectal cancer cases are among top 5 most frequent cases reported. March month is observed as Colorectal Cancer Awareness Month to make people aware that colorectal cancer can happen to both men and women. It is important for individuals to learn about the prevention, management, and treatment options of colorectal cancers. So, today, Voice of Healthcare, in association with Zydus, has taken up this initiative to contribute our bit towards this global drive of spreading awareness on this very sensitive subject. Let us start by inviting some very eminent people from this field. We feel very privileged to have some very eminent professionals from the field of oncology here with us. I welcome Dr. 𝐂𝐎𝐍𝐶 Mohana Vamsy, who is the Chief of Surgical Oncology and founder of Omega Hospital in Hyderabad. Welcome, sir.
Dr. Mohan Vamsy
Next, I'd like
might take.
to. Sorry?
Dr. Mohan Vamsy might take some time to join.
Yeah.
We'll be asked to proceed.
He'll be with us shortly. Next, I'd like to welcome Dr. Vindhya Vamsy Andra, who is the consultant of medical oncology at Omega Hospitals in Hyderabad.
Good evening, all.
Next, I welcome Dr. K. Madan Gopal, who is the senior consultant of NITI Aayog at NITI Aayog in Government of India. Next, I'd also like to welcome Mr. Ashish Kumar, who is the Vice President and Cluster Head of Zydus Cadila. I also welcome Mr. Raktim Chattopadhyay, who's the founder and Chief Executive Officer of Esperer Onco Nutrition. Now, I take this opportunity to hand the session over to our moderator.
So Dr. 𝐂𝐎𝐍𝐶, I think he was there, just I can't see him on the screen, so maybe he'll join in a second.
Yeah. Okay. Yeah. So till then, I'll just start the session with our esteemed panelists. Dr. Mohana Vamsy would be with us shortly.
So Dr. Chattopadhyay is there, and you can direct the Dr. Mohan Vamsy question to Dr. Vindhya Vasini.
Okay. Hello. Am I audible?
Yes.
Yes, sir, you are audible. I'll just go off now.
Yeah.
Please take it ahead from here.
There are some internet issues, Wi-Fi issues. That's what I think I had to log off. Good evening, everyone. Good evening, all esteemed panel. I think the subject that we are going to talk or going to listen from all of you is something is need of an hour. Uh, I we know that entire focus of cancer treatment has boiling down towards the detection. Early detection is the key that has been already been highlighted uh, for many years. And India as a country, the screening awareness, those things matters a lot. It's the socio-economic conditions of India. It's not supportive. Even there is an options available. We all know. So, uh, Dr. Vindhya Vasini, you are, uh, an active practice, and you see day and day out a lot of patients, and the prognosis of the patients must be surprises you sometimes. Um, so, how do you, for the common people, can you just tell us that what are the common signs and symptoms for colorectal cancer, which a normal person can understand and rush to the medical fraternity?
Yeah, that's a very important question, and it gets asked quite frequently. Most of the patients or most of the general public whom I interact with, they want to know what would be these warning signs or red flags that they need to look for, and then address them at the earliest. So, unfortunately, like other cancers, even colorectal cancer in the very early stage might not have any symptoms or signs. They might be totally normal, but a few symptoms and few signs which must make them alert and seek medical attention immediately are very important to notice and remember. The first thing is the change in the bowel habit. So when there is a change in the bowel habit, be it constipation or a diarrhea, that is increased frequency of passing stool, when this occurs for a quite a period of time, say a few weeks, 2 to 3 weeks, without any other identifiable cause, that should be a cause of concern, and it should raise the suspicion of something abnormal in the gut. The second thing is the change in the consistency or the color of the stool. The stool might become dark, or it might become watery or tarry stools. These also need to be addressed immediately. And all these symptoms are not diagnostic of cancer, but they raise the suspicion for cancer. And the third one is the change in the caliber of the stool. The stool might become narrow in caliber, and then this could be because of a tumor which is causing the narrowing of the lumen. Then another, as the stage advances, there might be frank blood in the stool. Um, Blood in the stool per se can be caused by several other causes, and especially the most common cause we see is the external hemorrhoids or piles, which is normally a normal term used in the colloquial languages. So piles also are the most common cause of bleeding per rectum, but that bleeding is usually associated with pain. When there is a painless bleeding per rectum, that is more serious issue and cause of concern, and the person should immediately seek medical attention. And other than this, there is this feeling of bloating of abdomen, pain in the abdomen, or back pain, um, or abdominal discomfort which is unexplained. And as the cancer progresses or advances, there might be this feeling of incomplete defecation. So when the person goes to pass the stools, there's a feeling of incomplete passage. They might feel that it they didn't have a free passage of motion, and they need to again go for the use the washroom. In such, that could be because of a tumor obstructing the lower part of the digestive tract, lower part of the large intestine, which causes this feeling. And as the stage advances, like in more advanced stages, when it spreads to other parts of the body, there might be development of abdominal distension or jaundice because of the involvement of liver, breathlessness when it involves the lungs, bone pains when the bones are involved. There might be severe back pain, bone pains, leg pains, and also when it spreads to the brain, it might cause some CNS symptoms like seizures or headache, vomitings. So, this signs and symptoms may vary based on the stage, But importantly, very early stage cancers might present as totally asymptomatic, and the patient might only see a change in the bowel habits.
Okay, great. I think this is the simplest way of making all of us aware about the signs and symptoms. I have just one queries, probably as a layman, even that how most of the symptoms that you talked about, maybe it is overlapping with the other problems, other medical conditions, and in that case, normal person definitely would not rush for an oncologist. That's naturally either will go to the home or house physicians or maybe in a some local doctors. So
Gastroenterologist.
in your practice, how do you see that? What is the prognosis that you are seeing? What stage the patients are coming, considering these symptoms?
Generally, in our practice, unfortunately, in India, we don't have this, widespread screening procedures and the lack of awareness in the general public. And majority of our patients, they present at a very advanced stage. Usually, stage 3 is the most common. Some may present early stage, like stage 2. But usually, they present at an advanced stage. They are mostly referred by general practitioners or gastroenterologists once they evaluate and do a colonoscopy and find a tumor or a polyp, and then they do a biopsy and send the patient to us, refer the patient to us for further treatment.
Oh, great. We'll come back to in this sometime later. For the time being, let us go. Dr. Madan Gopal, we have with sir. You represent the government, NITI Aayog. So, we have seen in past few years there is a huge initiatives from the government, especially focusing on the cancer, disease control and preventions, and a lot of other things, especially in the early detections when you are talking about colorectal early detections or any cancer early detections. So what kind of initiatives government should take or government can take or maybe government is taking for the early detections, considering the lot of challenges that is having India being a diverse country? Sir.
Dr. Chattopadhyay, thanks for this opportunity to share my thoughts in this workshop. Sorry for joining late. I was on my way back from my office, so that's why this delay has happened. So anyway, nevertheless, as you are aware that we are having a national program for prevention and uh, control for cancer, cardiovascular disease, diabetes, and the strokes. That program is there, which has been launched, which has been implemented. So in that program, apart from the population-based screening is also there. We are trying to focus on increasing uh, strengthening the infrastructure, building manpower, as well as early diagnosis, treatment, and referral. That kind of mechanism is there. We call it as NPC DCS TC program, which is already there. A structure is there. But if you look at the major impetus was given to the NCDs and this cancer screening through through your when we launched the comprehensive health and wellness program, that is comprehensive healthcare, primary healthcare. So in this comprehensive primary healthcare, apart from the reproductive RCH program, we have now extended to include NCDs as well as population-based screening. That means, as has been pointed out, but the program is more or less focused on the detection of the oral cancer, breast cancers, and cervix would be added to that, apart from screening for the non-communicable disease. The screening for this colonic cancer is not there right now in the gamut of this population-based screening, because that the focus is more or less on that. But still, that is the uptake is to happen, because the comprehensive primary healthcare, which was launched 2 years back, with the upgradation of the sub-health center, which is the peripheral most health institution of the health system in the public sector, at a population of 3,000 to 5,000, based on previous norms, population norms. That has been upgraded to health and wellness centers. And this health and wellness center, they will act as a nodal point for detection and screening for this non-communicable disease. We had One of the component which is included is a population-based screening. We have a frontline worker every village and habitation. So we would be having a ASHA workers. So in some place they are called Sahiya, some places they call ASHA. They are the community level outreach workers. They are there. They are not part of the system, but they are very much part of the system. They are all volunteers to support the activity of the health worker female and the health worker male. Health worker female is the ANMs. You already know they are the peripheral more extension worker of the health system. To assist them from the community level, you are having an accredited social health activist. They are given incentives for helping the uh, the health system for bringing in patients for screening and other things. So what we are trying to plan is we are trying to have a checklist kind of approach so that an assessment can be made then and there at the community level. So that any person who are falling in that checklist can be expanded to include the common symptoms as the column common symptoms like for this colonic cancer that can be included there. So that once an assessment is made, the patients can be referred to the primary health center where they have the first contact with the doctor or the community health center and a proper treatment can happen. But nevertheless, one of the important thing which is there in the health and wellness center is the use of IT technology and IT platform. Now we are experimenting that how it will come. In the primary health center during the COVID time, the e-surgery has worked. But how this, based on the checklist assessment being done at the village level by this ASHA workers and the ANMs, how they can be connected with the peripheral higher centers. Some models, pilots are happening. How they can be connected so that an early detection, early diagnosis of cancer can happen, including the colonic cancer and the other cancers which we are screening. Because in population screening, we can't be focusing on one particular cancer. It has to be a gamut of many other things. We are trying to focus and see that how we bring all this thing together and see how things happen. I stop here. I will take more questions.
I think, yeah. Sure. I think there are two very important things that you have highlighted, which I can see. One is you talked about the ground level workers who are day in day, that there is an infrastructure has been used, which is a day in day out, can be village level, so they can reach to and get the real information. And second thing, you talked about assessment. I think Dr. Vindhya will be happy to hear this also. Assessment in cancer with the checklist, it is something which must need. And if government is working on that line, I think this is the first level of screening, which is a checklist based assessment. So if we can work out that, I think that will be great. Great, sir. So we'll come back to you again. We have also Mr. Ashish Kumar from Zydus, who is the host of the program. And Ashish, you are representing one of the biggest pharmaceutical company in India. So we have seen that Zydus has been, been responsible for carrying out various serious areas. So when it comes to the pharmaceutical, the quality, accessibility, and affordability, these three things matters. And when it comes to the cancer, it becomes a mandate. It becomes a very crucial thing. So how do you think that in case of colorectal cancer, the Indian pharmaceutical companies or industries are intended adding value in serving good quality products with the right reachability and obviously the accessibility?
Thank you. Thank you for that question, and thank you for putting that across to me. But first, I think it was great to hear from Dr. Vindhya and Mr. Gopal on their comments on such relevant areas. Dr. Vindhya alluded to the signs and symptoms, and then we heard how government is actually getting into the screening. So when we talk about pharmaceutical industry, first of all, I think we are part of that ecosystem, which includes clinicians, hospitals, government, and then us. And together, all of us actually have to ensure that the cancer care in the country improves, and nobody in isolation would be able to achieve much. But when all of them come together, I think a lot can change. And I would also want to mention here that if you look at the India's cancer story in last 2 decades, uh, we would see that a lot has changed from, if we talk about the late 90s or early 2000, there were only a handful of cancer centers in India, where almost every patient was supposed to travel extensively for cancer care because there were only very few cancer centers in India. And from there, a lot has changed. Today, if you look at any major city or even tier 2 city, where we say we're tiring of that city 1, 2, 3, earlier we had only few cities with cancer care centers. Today, not only metros but sub metros, tier 2 cities, most of them have at least few quality cancer care centers. If I talk about number of oncologists, and the number of oncologists have increased by at least 5 times, though they would not be sufficient for the population we have, but I think we are catching up. And in these 2 decades, we have at least good oncologists across all the major cities, helping the patients improve cancer care. And when we look at this infrastructure, when we look at these number of oncologists, and then most important, the government coming up with so much of support, I think Indian pharmaceutical companies have also taken a very giant leap in ensuring that the high quality, affordable cancer treatment comes within the reach of the most patients. And the shared reason is the scale, the probably burden which our country has. And the companies, because of this scale and good practices, have been able to bring down the cost substantially. If I look at the cost index, and look at the cost at which the good quality cancer care drugs are available in India versus any index in the developed countries, though our GDP might not be as high, our household income may not be as high. But if I look at even at the household income versus on the percentage of the at what price the medicine are available, India scores pretty high today. And very happy to also share that this has also been possible because Indian pharmaceutical companies are not just providing the cancer medicine in India. The whole Western world, the day a drug gets off patent, any cancer drug gets off patent, most of the Indian pharmaceutical companies have been the one who are first to register those products in the developed nation and are able to provide the best of cancer care drugs even in the developed nations. If you talk about US, I think 80% of the generics cancer care drugs would go from India. So this also helps to ensure that we bring down the cost further in India by the scale which we have been able to produce. And then I think the most important thing is also that because the cost of the quality drugs in India by the Indian pharmaceutical company has been brought down to so low, if I look at a lot of government programs, the state and central government program, there has been a lot of collaboration where we today see most of these states either have Ayushman or then have the other, like if I talk about, I am talking from Gujarat, we have here My Yojana. Dr. Vindhya is talking from Hyderabad.
Yeah,
There we
I
have
am not able
Aarogyashri.
to hear you
And
properly. Are others are able to hear, Ashish?
Yeah, yeah. I'm able to hear.
Yes, very much. I think there is some connectivity issues, Radim, from your side.
Oh, maybe. Okay, okay.
so that is what I was alluding to, that because of the whole ecosystem growing and the quality medicine being available, now government through various schemes are also being able to serve a lot of more patients in India. Now, if you go, most of the states today are able to also cater to the society which otherwise would have not have had access to any of the cancer medicine. So that is how the pharmaceutical companies have become part of this ecosystem, supporting the infrastructure, oncologists, and the government in ensuring that the medicines gets available. And if we're talking about the colorectal cancer today, then the basic protocols, whether it is the FOLFOX or FOL-free, which otherwise would cost thousands of dollars in the developing nations. In India, we have the approach where these are available in thousands of rupees, and most of the patients today can have access to it. So that's how the Indian pharmaceutical companies are playing their part. Over to you, Mr. Chopra. I think, Mr. Chattopadhyay, we have some signal issue at your end.
Mr. Chattopadhyay, you can mute your video so that the bandwidth is preserved and you can moderate.
Yeah, I think he would join back again.
I think the organizers might
No issues. We can talk ourselves and continue the discussions about this colorectal cancer. So Vindhya
yeah.
ji,
I will
what
ask.
we can do that because otherwise we are live now, so it doesn't look nice. As I have shared that we need to have a checklist for the people who are working at the community level. What
Hmm.
are your views on this? How you
So
can take,
what
how you can
exactly,
see
what are
that?
the points that you are planning to allude in the
No,
checklist?
that's for the detailing thing. That what are your
Hmm.
views? How effective it would be? How we can build capacities? How the technology can be leveraged into this for implementing this kind of screening program? That's at least a basic assessment. Because
Yes, sir.
right now we are focusing in the from the health and wellness centers and this NCD program, we are
Hmm.
focusing on screening of all 30 plus population.
Okay. Hmm.
But the colorectal cancer is more or less common in 50 plus
Above
population. How we
50.
can take
Yes.
it? How we can
Hmm.
use this assessment checklist for taking the things forward?
I think, sir, that is a very, very, innovative thought that has been, trying to be implemented. Having a checklist and, educating these health workers to go into the society to first do a preliminary screening of the population, and then selecting the people who are, who have a high risk according to the checklist. Um, Doing more in intensive screening in them would be a good initiative, sir. I really think that's a
Yeah.
good
Apart
idea.
from that, what do you think that the other support structures would be required? Because once an assessment is made, there need
Yes.
to we
We
need to
need.
build in some certain support structure so that after the assessment, if the person is referred, what kind of structure you can envision for that?
So
Then I
at
will
least
come to Ashish
uh,
Kumar ji, how they can support it.
at least a basic basic lab procedures like checking for an occult blood in the stool. I think that would be a basic test that can be done in the community level health centers.
Okay, Ashish ji, how we can take it forward because you have spoken something about the CSR things. So at the community level, because we can for to popularize and make it more early detection of this colorectal cancer. Population-based screening is the answer, but The priority right now in the program is to screen for oral cancer, the breast cancers, and the cancer
Cervical
cervix.
cancer.
Cancer cervix is also not picked up. To
Right.
bring that into that, we have to make a case for that. One is the assessment. After the assessment, we need to see that how people are brought to the PSCs and the CSCs or referred to the nearby center which is attached to that place. So, what kind of facilities we can envisage that this should be the minimum things which we can do at that place, so that early diagnosis can happen, the people can be brought to the centers, and if appropriate, they can be linked to some appropriate cancer centers for providing more treatment.
Yeah.
That is the
So
whole game plan.
absolutely,
Please.
absolutely, Mr. Gopal. And I think if I go back to what Dr. Vindhya also alluded to at the start of his of our conversation, that unlike the other cancers, especially if I look at the breast cancer, where I think so much is talked about today, we have so much of awareness about the breast cancer, and the only reason is last 10 or 20 years we have been talking about it so much. There have been so much awareness spread, so many bodies, organization, NGO, companies, uh, clinicians coming together, holding forum, walkathon. But then when you look at a disease like colorectal, you would see in the perspective, I think the effort would not even be 5%, 10% as we do for the breast cancer. So the first thing is, I think all of us as different organizations have to come together and talk about. And as Dr. Vindhya also alluded to, that there are simple things. Even if we, before screening, we also make the society aware about the simple changes in the bowel movements, certain changes which their body is undergoing. And because we keep ignoring all those signs and symptoms, we might keep thinking that this might be simple diarrhea, this might be simple constipation, or certain things which we are in control of. And the situation becomes out of hands, and it is only in the very late stages that we realize and go to a clinician and then get referred to the oncologist when it is already stage 3 and stage 4. So I think first of all, I would definitely refer and allude to the point that it is all of us will have to come together and make the society more aware, and those forums have to be created as have been done for breast cancer. The other thing is there are simple tests, as you were also alluding to, especially the FOBT test or the blood stool test, which are there. And I'm not sure that even these simple tests are being referred too commonly to the general public, and this keeps on getting ignored. So I think even in the screening programs which you were mentioning, that you have ASHA workers or certain society workers in each of the cities and centers, which probably are helping on these screening programs. At least the FOBT test or these simple blood stool test should be part of most of these screening programs, because we can't make colonoscopy as part of the screening programs. But at least if there is awareness about the bowel movements and the simple examinations which Dr. Vindhya was talking about, and get these basic tests at least part of the screening programs, we should be able to probably get a lot of patients at the earliest stage. Kerala is part of our country, and if we look at Kerala, I think they have a lot of such screening programs as part of their most of the city screening programs. If you look at Kerala, the chances of clinicians seeing the early patients in the colorectal cancer is much higher than if you go to north. So the north versus Kerala, it's a totally different story. And the only thing is, because the society there is much aware, because it's being talked about, the basic screening programs are simple tests which can probably recognize and probably find out these diseases early. So I think talking it about more than what we do, and also having the basic simple test like FOBT as part of the initial screening programs can make a lot of difference, and we all can together work for same.
Okay, thank you, Ashish ji. I think our moderator, Raktim ji, has joined. Raktim ji, over to you. We were just taking the benefit of the technology glitch, and we were discussing some aspect that how we can improve and how we can leverage the facilities which are available and the other things. Over to you, Raktim ji. Raktimji,
Great.
what you can do, you can just
Can you hear me? Thank you,
yes.
Dr.
What you can
Vindhya.
do, Raktimji, I will suggest that you just mute your video so that you have bandwidth and you can speak. Okay. Yes, please.
Yes. I'm sorry. I don't know what happened.
No, it's fine now.
So
Now
I
we
have a
can hear
question to
you.
Dr. Vindhya. It's okay, great. So let me ask you one question, Dr. Vindhya, that we all know that colonoscopy is the gold standard for this screening. But we know the barriers of colonoscopy, considering the health infrastructure that we have. So what are the options that you see, and how do you manage the screening part of CRC?
Yeah, so obviously, yes, colonoscopy is the gold standard, and if available, that would be the preferred method to screen the population. But in our country with this huge population, a number of colonoscopes required would be unimaginable, and it would be nearly impossible to procure so many colonoscopes and then do this screening for everyone. So the alternative would be a fecal occult blood test, or it is a very simple test, but it needs the stool sample to be evaluated. The patient needs to submit the stool sample, and if the sample is negative, it needs to be done every year. Yearly screening should be done with this fecal occult blood test. Other options would be a sigmoidoscopy, which is inferior to colonoscopy. It only checks the last terminal part of the large intestine, where it is more the colon cancers and colorectal cancers are known to be more common in the descending colon, the distal part of the colon and the rectum. So to some extent, it might be helpful in screening, but it is not a replacement for colonoscopy. There are other methods like the virtual colonoscopy, which is done with a CT scan. Even those would be difficult to be implemented in the large scale. So, if for our population, the best method to screen would be the fecal occult blood test, blood test, to look for occult blood. So, usually, what happens is if the tumor in the colon, in the intestine, it is very friable in the sense it is rich in vasculature, blood supply, and it easily bleeds on touch. And when there is a passage of the fecal matter, it erodes the tumor on the surface, causing small bleeds, which might not be visible to the naked eye, and the stool looks normal, but when we test the stool for blood, it comes positive. And this is one method of screening. Another method may be doing a blood test to look for anemia, which might, again, especially in males, anemia is not common in males. And if there is anemia, we might go ahead and look back for the occult blood test. But that is anecdotal kind of a situation. But for a population based screening for colorectal cancers, stool occult blood test would be a feasible option in our country, where a huge population needs to be screened. And recently, the guidelines previously used to, advocate colonoscopy screening after 50 years, and now they have reduced the screening age from 50 to 45. So more number of uh, uh, people need to be screened now. So that would be nearly impossible with to if we are considering colonoscopy as a method. So fecal occult blood test, FOBT, would be
Okay.
a feasible option.
Okay, I think that gives a lot of clarity. Thank you, doctor. Now, since we are talking about screening in depth, so I have back-to-back questions to you again, Doctor Vindhya.
Yes.
It's India does not fall under developing country anymore. In all the sphere of the development, India has progressed, and so in healthcare. When you see that pharmaceutical industry, how they are serving, even in this vaccine time, in the COVID times, we have seen how India has served the world. So, keeping that into the mind, how do you see that treatment options, which are the treatment options which are available, how it vary from the countries that we used to say that they are better than us? But, current conditions, even the infrastructure, treatment options, awareness, number of consultant in oncology, all has been improved, even the machines and other technologies. So keeping in that in mind, how do you see where the treatment options vary? Is there any variations in the standard treatment options than those Western countries?
Yeah, that's a very, very, interesting topic. Though we are very backward in the screening part of the tumors, of the cancers, the treatment wise, interestingly and fortunately, we are on par with all the Western developed countries, and we have all the infrastructure. I mean, I don't say in all the areas and every place, but we do have. Tertiary care centers which are well equipped on par with the Western hospitals, and especially for surgical treatments, we have good colonoscopy guided polypectomies for the very early stage cancers, which are very less invasive. And then there is extensive robotic surgeries if it is planned, but they are usually very extensive open surgeries. And then when we look at the use of radiotherapy, which is most commonly used in rectal cancers, we have the latest radiation equipments, be it the equipment or the planning systems, the IMRT, IGRT, VMAT, SBRT, all sorts of radiation planning systems and the equipments. World class equipments are available even in our government regional cancer centers. These equipment facilities are being used to benefit the poor. These facilities and also these facilities or these treatments are available to the general public under the healthcare schemes, government healthcare schemes like the Aarogyasri healthcare schemes, where all these high-end treatments are being provided free of cost to the needy patients, the eligible patients. In coming to the chemotherapy part, we follow I mean, unfortunately, our Indian guidelines are still under development. We, as a cancer consortium, we are forming a cancer treatment grid where all the cancer centers in the country are coming together to form our own guidelines, which would be suitable for our patients. But until then, we are following the guidelines, especially the US guidelines or the European ESMO guidelines. For the treatment of the cancer, and all the various drugs or chemotherapy drugs, be it chemotherapy drugs or the targeted therapy agents like cetuximab, panitumumab, or the bevacizumab, even the immunotherapy drugs like pembrolizumab, nivolumab, or other targeting agents like ramucirumab, newer drugs like regorafenib, all are available to us. And in fact, most of our drugs are being exported to other countries. So, equipment wise, treatment wise, availability of drugs and radiation equipment and treatment plans, the know how, technological know how, and the knowledge, I believe, is on par with the Western countries, at least in the tertiary care centers. And yes, even in the tier 2, tier 3 cities and towns, there are good equipments to treat cancer. Especially cancer requires multimodality treatment, surgical, radiation, and medical oncology should work as a team to treat the cancers. And all the facilities are available with us. And I don't believe even the affordable patients, affluent patients are they are opting facilities in our country for the treatment other than flying to the Western countries for treatment. So it's in a good path that we are moving. uh, so I believe we have
Great.
all the equipment and necessary know-how for the treatment.
Okay, great. That's a great highlight, I would say. We'll go to Dr. Gopal once. Sir, in India, when it comes to the India and serving the healthcare, the underprivileged populations has to be taken care, and we have seen in recent times that he focused 100% on that.
Okay, I guess we are having a major network
Dr.
issue
Gopal?
from Mr.
Yeah, I'm
Raktim's
not able to
side.
follow because your voice was
Yes,
cracking.
yes.
And
So I'll
can
just
you just
repeat
type
the
in the
question.
chat so that I can reply?
No, sir, I'll just repeat the question on Mr. Raktim's behalf for you. So, which question he was asking you was, what measures have been taken by government to promote early detection, especially for the underprivileged population of our country? We see the privileged population coming for early detection, early screening through getting educated from the internet or Google or through clinicians, in tier 1, tier 2 cities. But what about the underprivileged population who is not so informed, who does not know that this problem is a threat to their life? And so what all measures the government is taking to promote early detection, especially for such underprivileged population?
If you look at the thanks, Dr. Sawan and Raktim, I think you are able to hear us. I think in the opening remarks,
Yes,
I mentioned that what the government has been doing. I will take the things further because most of the people, most of the facilities which have expanded, they have expanded in the rural areas. We are now focusing. We do have an urban mission also, which focus on strengthening this infrastructure in the urban area, so that a detection and other things can also happen. In that front, things are happening. In any government institutions across the country, it's more or less either subsidized treatment or free of cost treatment. That means the underprivileged, they can walk in, even you can walk into any government institution and either gets a subsidized treatment, or if you fall in a underprivileged class, that is a BPL or some deprived, socioeconomic deprived class, then you are provided free treatment there. In Ayushman Bharat, I have just mentioned about the comprehensive health, primary health care, which was rolled out by the government. The comprehensive healthcare is part of the Ayushman Bharat. Ayushman Bharat is having two components. One is the comprehensive care, which is being rolled out through the Health and Wellness Center. I have already mentioned that through the Health and Wellness Center, we are doing the screening for NCDs under the National Prevention and Control of Cancer, Diabetes, Cardiovascular, and the strokes. That program is launched out, where the 30 plus population is targeted and the population based screening is happening through the ASHA and the ANMs. Side by side, the other component of the Ayushman Bharat, the PMJ program, Pradhan Mantri Jan Arogya Yojana, wherein 500 million people are being covered, have been provided secondary care after detection. In this, a lot of procedures for the colonic cancer, the colorectal cancers are there, right from colonoscopy to this. Interestingly, in all these packages, the pre-hospitalization, that means the pre-diagnosis and the treatment as well as a follow-up medicines are there. It's a package. It's evolving. To begin with, we should have some packages. It cannot be perfect, but the things are evolving. But another beauty of this program, which is meant for the underprivileged or the population who are socially and economically deprived, around 500 million people, you see that in this program, I just lost the thread. What has happened, apart from screening, because this screening is there, the packages are there. When we started this program, we have to start somewhere. One of the beauty of this program is that all the things are covered. It's not the package. Packages are easy for administration of the scheme. If some package is listed, 1400 plus packages are listed, that's for ease of administration. If the person is having any other affection, he's a beneficiary of this PMJ program, he can get treatment under the unclassified packages. The hospital has to just seek a pre-authorization, and pre-authorization in the turnaround times are being well defined. In that turnaround times, I think the package is approved and the patient get treatment. For this is about the treatment plan. But regarding the early diagnosis, that's still a challenge, and we are trying to see how we make an assessment through the community workers and the outreach workers, because the awareness regarding this colorectal cancers is very less. Now people have started thinking
Sir,
about the oral cancers,
sir,
the breast
Dr.
cancer.
Dr. Gopal, Dr. Gopal,
Yes.
thank you. I think we are running a little short of the time, so we'll come back again. I will go to Mr. Ashish with the vital questions that India is the center talk of Indian innovations in biotech in recent days. And biosimilar has got a lot of role in oncology, we have seen it. In case of CRC, can you just tell us in brief that how the biosimilars are improving the quality of treatment in case of colorectal cancer?
Sure. Uh, See, before we talk about biosimilars, biologics, as we know, as Dr. Vindhya also alluded to, that there are the specific targeted agents which have improved cancer care outcomes significantly because they have fewer side effects. They directly target the sites, and unlike the chemotherapeutic agents, they don't target all the actively dividing cells. But then the biologics development are extremely costly because of difficult to develop processes, which also makes biologics out of reach for most of the patients or many patients. However, with the biosimilars advent, now every country today is talking about to bring down the economic impact of the healthcare burden, and the cancer care is a huge healthcare burden. So with biosimilars and the accessible biologics, a lot is actually changing. India today stands at the cusp, as you were talking about, because India today is the leader in biosimilars. India today has approval of over 100 biosimilars in the last decades or so, and out of this, 80% of the biosimilars have been approved in the oncology indication. If I talk about EU, European Union as a whole together, it has only 50 biosimilar approval, and US has only 25. So when we talk about biosimilars, then India is far ahead of even the developed nations, and it is because of 4 to 5 Indian pharmaceutical organization taking lead in developing the biosimilars. Now coming to the colorectal cancer, if I talk about various publications which have come from the leading cancer centers, it clearly reflects that before the biosimilars came in the colorectal space, especially I'm talking about the bevacizumab here, the penetration of bevacizumab to the eligible patient population pool was less than 5%. But now with 4 to 5 Indian pharmaceutical company coming with the biosimilar of bevacizumab, the access has improved to almost 45 to 50% in last 5 to 6 years. So that's the impact. Almost 10 times increase in access because the biosimilars are getting available at an accessible price. And many of these biosimilars are also taken up by various government schemes, as Dr. Vindhya and Dr. Gopal were alluding to, like Ayushman Bharat, which has a cap of 5 lakh, many state schemes which provide funding of 2 to 5 lakh. With the biosimilars at the accessible price, most of the now CRC patients have access to not just the chemotherapeutic agents, but also biosimilars like bevacizumab. So the access is increasing significantly year on year with the biosimilars coming in.
Great, Ashish. I think you have given a very valuable information here. We are running short of time. Still, we will just like to know from Dr. Vindhya once again in a very short, 2 minutes answer that studies have shown that fiber helps by keeping the digestive process moving. So cancer, causing sprain last time in the colon. Can you please touch upon this and explain us that specific dietary recommendations to help the colorectal patients? You're mute. You're mute, Dr. Vindhya.
Sorry. So yeah, can you hear me now? Yes.
Yeah, absolutely. Please go on.
Yeah. So several studies have shown that increasing the fiber content in the diet decreases your risk for especially colorectal cancers. This is thought to be because this fiber, it absorbs the majority of the carcinogenic toxins in the gut, intestine, and also it reduces the transit time of the waste matter in the colon. So it reduces the exposure of the colon to the toxic substances in the fecal matter, and thus decreases the risk. So what are the various fiber rich sources, or how much fiber do we need to take? It is thought that around 30 grams of fiber per day is ideal recommendation of to have a healthy bowel habits, and also reduce the risk of cancer. So various sources of fiber, all the natural fruits, vegetables like cereals, wheat bran is thought to be a very good source of fiber, and it is known to reduce the risk of cancer. And also intake of colorful, your plate should be colorful, like it should have all the colors like yellow, orange, red, green, and then include carrots, green leafy vegetables, light green vegetables, and make sure that it has lot of vegetable sources of fiber. Then there are use of whole grains rather than refined flours, refined maida, or such kind of things. And also studies have shown that use of red meat, especially red meat in the sense use of beef, pork, or lamb, which is not that quite common in our country, but in the West it is more common. Not only that, this the type of processing we use for the meat, like smoked food or barbecued food. When you barbecue the meat, you see black stripes on the meat. So in fact those look nice, but they are very harmful to the body. They have these nitrosamines, which are cancer causing chemicals, and they increase the risk of cancer. And of late we see a lot of these fast food centers. Every corner has a McDonald's or Kentucky Fried Chicken or some whatnot. And the consumption rate is so high now that the incidence is increasing at a very rapid pace, and even very early age we are seeing cancers developing. And not only that, use of intake of high calcium like dairy products increases the protection level, because they absorb these harmful bile juices and all the chemicals, and prevent the interaction. So use of on and also strangely, vitamin D deficiency, which is very common, even though ours is a tropical country, vitamin D deficiency is very common in our patients, in our population. And correcting the vitamin D deficiency by supplements also reduces our risk of cancer. Not only that, limiting the alcohol intake is and smoking cessation are very important in reducing the risk of cancer. These are all modifiable risk factors. On top of that, most important is the lifestyle modifications. Use of having a more active lifestyle, exercising at least 30 minutes in a day, being active for at least 30 minutes in a day.
Yeah.
Or
So, Dr. Vinda, I have to
yes,
stop
please.
you here. I'm sorry,
Yeah.
but I think you have given the informations which it's very vital for the layman language. Thank you, gentlemen. It's a pleasure time. I think there are a lot many questions that is coming, and even I have in my mind, but time is something we cannot go against of it. So I think we talked about early detections, we talked about treatment options, we talked about the unprivileged populations serving, we talked about the newer options like biosimilar and treating the quality treatment of CRC. So thank you very much. I over to Dr. Sawant. Thank you very much again for all the speakers for giving their wonderful inputs here. I think this was been very useful for the entire community. Over to Dr. Sawant.
Thank you, sir. Thank you, everybody. Thank you, all our panelists, for staying with us despite the minor network glitch that we were having. Thank you, Mr. Raktim, as well, for staying with us and sharing your valuable, expert moderation on this panel. With that, we wrap up this very thought-provoking session. We got many new insights into colorectal cancer, how to avoid them, the prevalence, and specific to Indian population. We hope that this session was informative to all our viewers. And thank you for staying with us. We greatly value your time. With that, we are going to sign off now because of shortage of time. So stay happy, stay safe, stay healthy, and thank you so much.
Thank you so much for having us.